And you can hear us. We can just say hello to everybody around Chipata Central Hospital. Good afternoon.
Good afternoon, how are you?
Very well, thank you. How are we doing over there?
We are fine.
We are fine.
I can hear from the voices that we are very, very well. Okay.
Then English.
Dr. Bosco, it's been a while. How are you, sir?
I'm very much okay. Thank you, sir. Thank you. Welcome back.
Thank you for joining us. We really
Thank
appreciate
you.
your presence.
Thank you. Thank you, sir. Thank you.
Nice.
Okay, so I think we can be heard. We're loud and clear. And we've also been joined by Dr. Francis Mpeta. Dr. Mpeta, long time. Thank you, Dr. Muntali, for joining us. Yeah, and we do have a few other experts, subject matter experts that we're expecting on the panel. We've got Dr. Michael Kawongo, Dr. Wilson Walia, Dr. Emmanuel Ngomba, and also Dr. Mundia Mutumwa. Thank you very much for being available to enrich this discussion this afternoon. So we'll be looking at comprehensive HIV prevention. And in our midst, we have Dr. Wupe, who will be able to introduce herself and just tell us a bit about herself. And then she'll be able to carry on with the rest of the presentation. So I think we want to make sure that everybody is still abiding to our eco etiquettes, making sure that we mute ourselves when we join in, making sure that we raise our hands when we want to make a comment. And if you have any comments, please do post in the chat box. We are also requesting that you register. There's a registration link in the chat box. Please go there and just register yourself. I know some of us, maybe more than one person in an auditorium, but please do make sure that you register everybody that is in that space where we are sitting. I think having said that, we'll proceed and just hand over to Dr. Wupe Msonda to introduce herself and also just talk a bit about what she's going to present today. Dr. Msonda.
Good afternoon, and it's always a pleasure to be here and share knowledge and discuss all these interesting topics. For those that don't know me, my name is Wupe Msonda. I'm the HIV Prevention Advisor at the Ministry of Health. So basically, I help the Assistant Director of Infectious Diseases at the Ministry of Health to coordinate the HIV program at the Ministry of Health. Some of the topics that fall under my portfolio or programs would be mostly PrEP and the Adolescent HIV program. Other programs, HIV prevention programs, are covered by other officers at the Ministry of Health. So it's always a pleasure, and thank you for having me today.
Thank you very much, Dr. Msonda. We also want to appreciate our teams on the ground from Senanga Urban Clinic. Thank you very much for your hard work. You managed to put up a case that we're going to discuss this afternoon. And this is Victor Namitala, and also coming from Western Province. Thank you very much. I hope you've prepared yourself and ready to get on with the presentation once the time comes. So Dr. Wupe, I think you can pick it up now.
Thank you. So as mentioned, today we'll be discussing combination HIV prevention. I know most people, when they think of this topic, they think easy. What's there to discuss? What don't we already know? So this topic is just to talk about what's new where we've come from and why the program, for those of you who are active in the HIV prevention program, has taken the turn it has and all these new changes that are happening. So before we get into the technical side of things, I just want us to think, have you ever screened a client who's at substantial risk of HIV infection? And by substantial, we mean that they have proven or they feel they have enough evidence to show that they feel they're at risk of HIV. Have you ever screened such a one? And anyone? Maybe I'd want to hear. How many of you have such clients?
So please raise your hand if you've had such a client, because there'll be all those follow-up questions. Dr. Lloyd, hi. Please go ahead and unmute yourself.
Hello, team. How are you?
Very well, thank you.
Yeah, I think, good afternoon, everybody. I think this topic is so prudent that it's very difficult to change gears to say there's something that can prevent HIV, if you know what I mean, coming from where we come from. And I think us from old school, it causes a lot of heartaches and trying to separate those which need PrEP or those need PEP and those who really should not even get anything. So to me, I'm really looking forward to hear how we could just put the three categories without over-prepping, if there's anything like that, or over-pepping. Because at the end of the day, one has to be very, very prudent when doing this. I appreciate your comments. Thank you.
And there you have it, Dr. Wupe.
So I like, she's brought out all the important messages. And you know, I liked when you said the over-prepping, because we have such cases, and I think even the Senanga case will highlight such things, because people say, when do I know I'm doing too much or too little? And what?
To who?
And to whom? And I think most of the time we ask, especially for those of us who are overthinkers, when a client leaves, you're like, did I do enough? Did I really do all that I could? So we will discuss that, and hopefully Dr. Lloyd at the end of this presentation will touch on that and will answer some questions or make it easier for you. So other things we'll look at is, in our practice, what services do we offer such negative, HIV negative patients? What services do we give them? Do we just say, congratulations, you're HIV negatives, pat on the back, stay negative, be safe on your way? I know there's a lot of us who've done that. So now we have to think, what have we been doing? And when we think of HIV prevention, what comes to mind? Here, I'm interested in the answer, Dr. Ziambo, because I want to know what people think HIV prevention is. Anyone to take this one?
Okay, you've been invited to speak again, network. Please raise your hand if you have a comment to make.
It's not a trick question. I just want to know. Okay, I guess they're.
No,
hello.
Aaron has.
Hi.
Yes,
Hello.
Aaron, thank you. At least you've raised the network.
I think the issue of prevention. Hello.
We can hear you.
Hello.
Go ahead, we can hear you.
This is Aaron.
Please go ahead.
Yeah. I think for the issue of prevention, if one comes alone without a partner, that's where the main challenge is, because whatever you have to discuss to one partner,
Who know could be the problem? Like someone
the
has
other one will not accept
did.
maybe the methods you have given them to follow. That's one challenge we have been discovering, that, especially if actually the one who have come was the female, then you say, apart from whatever maybe abstinence, if not married, but use condoms. Are we still going to?
I think we've lost you, Aaron. I hope you were able to make out what he was trying to say.
I think he was talking about the different nuances of seeing clients. When you see a patient alone, sometimes what you offer and even the things you might think of differ than when they come as a couple. There's a different way we approach them. I hope I got you right, Aaron. The way the approach differs and even the answers they give differ when you speak to me on my own and when you speak to me with my spouse. So I think those are the issues. But I think he did say it's just about ensuring that someone is HIV negative and keeping them negative. I think that's what I got from what he said. I hope I quoted you right, Aaron. Obviously, I added some tomato and onion there, but yeah.
You want to hear another comment?
I think we can move on for the sake of time. So I hope this presentation will be as interesting, and please do engage. So at the end of this discussion, we will look at defining and understanding the real concept of combination or comprehensive HIV prevention. What really is it? What's the concept? And we'll look at what precautions or what recommendations have been made for HIV prevention globally, and then we'll bring it down to Zambia as well. We're still going to touch on PrEP, defining it, outlining the eligibility criteria. We'll also share some latest updates from WHO pertaining to PrEP. And then we'll just describe in brief. Remember, there was a separate PrEP presentation. So this one will just give a brief summation where we'll look at how to work up a client, timing of when to offer, when to discontinue. That's Dr. Lloyd's question, and so on and so forth. So this is what we'll be discussing today. So my first question, by the way, my poll questions are so easy, they'll be boring, but at least I think that they'll help bring things into context. My first question is, HIV prevention programs should be tailored by A, age, B, gender, C, social cultural behavior, D, economic or environmental factors, or E, all the above. So in other words, those of you who know what my job is, how do we tailor programs when we sit and come up with strategies? What do we look at? What things do we consider?
Do we consider A, age, B, gender, C, social cultural behavior, economic and environmental factors? Which one here is the correct answer? We have launched the poll, so please go ahead and pick your best answer. Please feel free to poll. We have done a very good job. Over 63% have polled.
Okay.
Yeah, I think I'll end the poll. So this is how the performance has been.
Okay. So most people feel all the above apply.
Yeah.
Okay, interesting.
Okay.
So we can move on. So I'll take you through a background of the HIV prevention program, where we're coming from, and hopefully leading to where we are. So when we first started the HIV prevention programs, they were centered around behavior, because remember, the theory then was it was promiscuity. So people felt that if it's a promiscuity thing, we should focus on behavior change. Hence, we started the ABC approach. For those of you who are not familiar with the ABC, I think for our generation, we grew up singing the ABC song. A was for abstinence, B, be faithful, and C was for condom, or use a condom. So I even remember for the adolescents, those of us who were growing up, we used to sing that song, abstinence iliche. It's the cool thing to be. So this was widely the response in sub-Saharan Africa. However, in the 2000s, as we started going into the 2000s, we started seeing that really behavior isn't the only thing we need to look at. For us to offer effective services, we have to consider a lot of other factors. Social factors, cultural factors, political, even the legal barriers and other factors that can influence for us to look at HIV prevention. So I'll take you through evidence of each of the HIV prevention methods, why we chose them in Zambia, what evidence provided us or gave us the confidence to offer them in Zambia. So when we looked at the abstinence, as we know, up to now, it is the only 100% effective method for HIV prevention. So abstinence, not having sex, is the only 100% right now. No other method can match this one. And not only does it prevent HIV, it also prevents STDs or STIs and pregnancy. Okay, so however, we have known that abstinence isn't an ongoing thing. It may change at different times in life for different reasons and even based on your risk. Next slide, please. We looked at B, being faithful. This one, sadly, no studies have been done, so we don't really have evidence per se to say how effective this method works. And because of this is why some people have thought that then being faithful is not an issue here, that we can have multiple partners. But no, just because we don't have evidence doesn't mean it doesn't work. It's just that no studies have been done. So those of you who love your research, that could be a topic of interest to see how does be faithful, by how much percentage does it really work? Otherwise, scientifically, we don't have evidence yet. Condom. And here we don't just say usage of condoms, we actually talk about consistent use. And what do we mean by consistent? Here's where I want us to understand. When we say consistent, it means always during sex per self-report. So it's just what I tell you. That's the difference. Not that what we've proven, but what I have told you, that I use it consistently. So because of that, a study that was done in 2002 by Weller said that it was only 80% effective. Why? Not the method itself, but because it's self-reporting. So self-report may not be entirely accurate, because I can say, yes, I use it all the time, but maybe I skip one or two, in couples. No, when I'm angry, that's when I use the condom. When we're back together, we don't use it. So there are all these other reasons that people come in. So the condom effectiveness increases, okay, when the condoms are used consistently, meaning always, and correctly. I would like to report that we still have a percentage of about 23% of people in Zambia who don't know how to use a condom correctly. I have been to remote places where when you ask them to demonstrate, they remove their thumb and put the condom on the thumb, because that is what was demonstrated to them. So those of us who are working in the communities and you love your demonstrations, let's also make sure our demonstration techniques are effective at being well understood. Next slide. The other part of the C was for circumcision, what we call voluntary medical male circumcision. A study was done in two groups. They did it in heterosexual men, so basically men who have sex with women. And they, Seinfried saw that in 2009, it proved 50% effective in terms of preventing HIV. Loevenson did one in 2021, last year, which increased. He said he found 53% effectiveness of circumcision. It would really be interesting for us to do our own study here in Zambia to see how effective is our own BMMC. That seems to be doing well in Zambia. How effective is it? By what percentage is it offering HIV prevention? For heterosexual women, this is now partners of men who have been circumcised. Studies were done, but it was inconclusive. Wawa did one in 2009, and then Baton did one, Weiss also in 2009, and Baton in 2010. So they did several trials, and they didn't have enough evidence to conclude that male circumcision, a male being circumcised and having sex with a circumcised man, reduces the risk of HIV transmission in women. There was D, for drugs. Here there was two things. We looked at using ARVs for treatment. So drugs for treatment. This is where the U equals U campaign came from. Here's when we talked about optimal use. Taking ART as prescribed and achieving or maintaining utmost viral suppression. So a study was done in heterosexual men and women where it showed that it was 100% when the viral load is below 400 copies. This is a study that was done by Cohen in 2016. And yeah, so basically it was saying that if somebody can adhere and take the ART as prescribed, they can estimate about 100% of them, especially after attaining viral suppression, then the risk of transmission is almost zero. We have other ARVs for prevention. This is where the PrEP comes in for HIV negative persons. A study was done by Rydell in 2018, and it's in heterosexual men and women, and it showed the effectiveness of about 88 and 90. Newer studies have shown about effectiveness of 98%. I just didn't quote them here, but these are the studies that made us take on PrEP as a prevention method. And yeah, we'll go into detail on PrEP, so I won't do. So now that we've understood the background and the evidence for which we chose certain interventions in Zambia, I would like to ask, all of the following methods are effective current prevention methods of HIV prevention, except, so meaning currently in Zambia, which ones have we chosen as the effective methods of HIV prevention? Which one is not? So out of all these, which one is not one of the current prevention methods for HIV prevention in Zambia?
So we have posted, launched the polls. Please go ahead and take your pick. Which of the following are the effective current preventive methods for HIV infection? Except.
Those multiple choice you hate, Dr. Ziambo.
Too much. So we hope you're able to pick. So there's 339 people on the call that are able to vote. And so far we have reached 200 plus. Thank you very much for participating.
Yes.
I'll end the poll. And share. So that's how people have voted. Most people think B is correct, with a few others saying the B is an exception.
Okay. All right.
Okay, please, you may go ahead.
All right. So now the definition of what combination HIV prevention is. So it's an approach, a combination approach that encompasses different aspects. We look at behavior, we look at biomedical methods and structural approaches. And we tailor these to those who are perceived substantial risk. And the hope of this approach is that it leads to steep reductions in HIV infections. So it's encompassing a number of things, thinking about a number of things to approach HIV, averting HIV infections. So because, like I mentioned through the history, because the sexual patterns are changing, the epidemic itself of HIV is changing, so many things are affecting HIVs, even sexual choices, risk perceptions. So it's become clear that not one method is enough to prevent HIV prevention. We have to think of a combination of things. So this is why we've gone, well, ABC has taken a background role, but we should not neglect it. Now the Adolescent Health Department is bemoaning, saying that we've concentrated so much on medicine and drugs, we've forgotten basic things, teaching them about behaviors, information. So we still want to bring back the ABCs, maybe just with a revamped message. So with that said, what is the goal of HIV prevention? We have to look at the rights. Rights, we're looking at people's ability to negotiate safe sex or sexual choices. Evidence, we're not just going to pick any methods. We have to look at evidence. What evidence do we have backed up? I think for those that I've shown you, you can see that most of the, in fact, all the methods we showed is 50 and above. So we have to look at things that have got strong evidence to make us back it up. And it's also community-based because we have to provide these services closer to the people. So it has to meet the specific needs of specific people and communities. We can't just pick a one-size-fits-all for everybody. Specific people have specific needs. So the goal then is to reduce the number of new infections by offering more than one proven HIV prevention intervention. That way we will sustain impact. So this is just a picture for us to be reminded which methods fall under where. So when we talk about biomedical, that's where we have the condoms and lubricants, we have testing, we have the treatment for prevention, we have PrEP and PEP, we have PMTCT and VMMC, and the needle and syringe programs. Structural, this is where we start looking at what things look at the access, stopping people from accessing services. So we have to look at things like GBV. Are there laws to protect people against stigma and discrimination? We have to start looking, is it things about decriminalizing certain things towards certain populations, and just basically what things have we put in place to make access easier for all, basically. Behavior we mentioned, this is now looking on your risk. Do you perceive yourself at risk? Then for the younger ones, comprehensive sex education. This is where the CSE program came in. That's also targeted towards behavior. We look at peer education programs. For your information, there is a peer education manual. It's available on the MOH website that looks at how peer educators can equip themselves to offer services. And then we also have social marketing campaigns where we promote all these products using all sorts of media, mass communication, even digital platforms. Next slide. This is to show you what WHO is recommending as the comprehensive package. So for WHO, this is what it means to provide comprehensive. If you're not providing, you even remove one or two, then it's not comprehensive. So what things have we spoken about? Behavior interventions we've spoken about. Condoms and lubricants, PMTCT, GBV, harm reduction. So this is about people who inject drugs. Hepatitis has been included as a part of the package. So we should screen and test for it and treat. HIV testing services, human rights and health. Mental health has been included. We don't just look at other factors, we also have to look at your mental health. Where are you psychologically in order to access services? We'll look at PEP and PrEP. It includes sexual and reproductive health. It includes STIs. So now we can no longer talk about HIV separate from STIs. It's all part of one package. Vaccination for cervical cancer and voluntary medical male circumcision.
Another poll.
So another poll. Now, this is about PrEP. Which of the following regimens have been recommended for PrEP use in Zambia? Oh, each of these have been recommended except. So which one of these following drug combinations is not recommended for use in Zambia?
So the network just launching the test, the poll question. Please feel free to respond. The following regimens are recommended for PrEP use in Zambia, except which one here is an exception?
I told you my polls were simple.
Yeah. We have got people here. Okay, so network, allow me to end the pause. And here you are. This is how we voted. Most people think D is correct.
Okay.
Others went for B.
All right. Okay.
So maybe you can just run us through these questions, the answers, and then move on.
Oh, we can move on?
Yeah, we can move on.
All right. So what is PrEP? Will be very simple. Remember, this is just for everyone to be on the same page. PrEP is the PR, which is pre, before. The E is exposure, an activity that can lead to HIV infection. The other big P is prophylaxis. So basically it's before activity prevention. So before you engage. this is what this drug is for. So it's the use of antiretroviral drugs which we give to HIV negative persons to prevent the acquisition of HIV infection. So by using these PrEP drugs, if you use them every day correctly and consistently, it means that you have these drugs in your body, and when you are exposed to the HIV virus, it will not be able to survive in your body, and therefore you won't be able to get infected. So that is basically how PrEP works. And like I said, it's been proven to be about 98, 99 effective if taken correctly and consistently. So what is, so what is WHO recommending? This is very important, and I hope you've seen what I've highlighted in red. So they've said we can use any combination that contains TDF, tenofovir, or TAF, combined with any one of the 3TC, FTC, so XTC, and should be provided as an additional prevention method. What does that mean? You do not offer PrEP alone as a standalone method. It is an addition. So therefore, PrEP cannot be offered on its own. It must be in addition with another service. That is and it's offered to those at substantial risk, and it's part of a combination of approaches. So we do have introduction of new long-acting drugs. I know we've been using the TAF, the oral drugs, but other drugs have come on the market. We have an insertable ring, which is dapivirine ring. We have an injectable one, cabotegravir, which we have recently approved for use in Zambia. It may not be available until the next year, late into next year. However, it's something we have taken on as Zambia and we consider approving. Other drugs are rilpivirine and islatravir, which may be soon available. So what are the updates? So this is WHO updates. We still have not, we're yet to adapt these into the Zambian context. So we're having a team that will adapt these new changes. These just came out of the International HIV Conference when WHO launched these. So we're still going to sit as a team to revise and adapt these to the Zambian context. But you need to have this for your information. So we've said for clients who are being offered PrEP, we can offer HIV self-testing as a complement to testing strategies. Why? Because we've noticed with PrEP users, we've told them they need to come back every 3 months and retest so that we see that you're still negative, but we've been losing clients. So we've said rather than making them come back for testing, we can offer them a self-test. Let them test themselves in their home, and then maybe they'll feel free and it won't be a barrier anymore. So it's an additional choice that they are recommending to countries. Another thing they're recommending is a DSD model, a differentiated PrEP service delivery model, where they're telling us to be more client and community centered. So let's move away from the health facilities and offer these more on a one-to-one basis per client and in the community where it's closer to the people and the barriers of coming to a health facility aren't there. So there's 4 things that they are saying that if you're going to pick this DSD model, there are 4 things you should consider when offering PrEP. The first thing is where? Where is this service located? If you're going to put it in a place that's hard for people to reach, who's going to come there? If you're going to put rules and regulations on where people offer this, is that going to be a barrier? Then also the who. Here, I think it's very important. We have to be mindful of who's offering the service. Some of us are not client-friendly. Some of us are judgmental. Some of us will be afraid to go there because it's my aunt, it's my church leader, we're in Mothers Union together, all those things. So who is providing this service? So for some people, they feel better. If it's a buddy or somebody I know, maybe if you play football, it's easier for me to collect as opposed to somebody else. So it's about the who. Then when to offer this? When do you offer this? If I have a 9-to-5 job that is strict, and that's the only time your center is open, then obviously I can't access. But what are you doing? Are you offering after-hour services for those that work during the week? Is there weekend clinics for those of us that don't manage during the week? So it's also the when we are offering. And what service package? And note the word package. So it's not just one thing. So it's not saying table of condoms on a table, I'm offering the service. No, packaged, a combination. Thank you. So another update that they've put up is hepatitis B and C. they say that for every PrEP service we offer, it is important to use this as an opportunity to screen for hepatitis B and C so that we can link them to care, because we know that, I hope we've seen from latest data that having hepatitis B or C puts you at 5 times risk of getting HIV. So we do need to screen for these. And new data is actually saying that even now people who are hepatitis B positive can safely take PrEP because they have seen that there's been no risk of rebound viremia, so it can be given safely. On kidney function, here I think a lot of people will be very excited. We've heard stories, hey, creatinine, we didn't have reagents. Sticks for urinalysis were OS.
That's the reality.
And it's a reality, we've all been there. And so now others are saying we can't offer PrEP because we don't have these things. So they have changed it a bit. They've said for those aged 30 to 49, without any kidney-related comorbidities, we can forego doing kidney function tests. What does this mean? Kidney function tests are optimal for anyone aged between 30 to 49 and you don't have any kidney-related comorbidities. But for the rest who fall outside this bracket, it's still mandatory that we do the kidney function tests. So I will add once again, these are WHO recommendations to countries. Zambia is yet to sit down and adapt. This will be done within the next 2 weeks, so we'll be able to provide new guidance on what we've taken on. So, which drugs do we recommend for oral PrEP in Zambia? We have the common one, Truvada, which is tenofovir disoproxil, fumarate, the TDF, which is taken orally. We have the lamivudine, which combined with tenofovir disoproxil, fumarate, TDF, which is called Tenolam. So those are the trade names. Then we also have a combined tablet of tenofovir alafilmide, which is TAF, combined with amitriptyline. So these 3 drug combinations are the ones that are recommended for oral PrEP use in Zambia. I just want to mention that they have shown that those who take TDF and FTC, it is secreted in the breast milk, but at such low concentrations, about 0.3 to 3, that are safe for a child, because most people felt that it's not safe to give this in a pregnant woman. But studies have shown that it's so minimal that the levels are actually required enough for infant treatment, so meaning it is safe to use during breast milk. Hence, you saw us recommending PrEP, oral PrEP for pregnant and breastfeeding women. Next slide. So, another poll question, which I think is our last one. Of these cases below, which women might benefit from PrEP against HIV? Those who are diagnosed with gonorrhea in the past 6 months, those who are diagnosed with syphilis in the past 6 months, those with a partner who is HIV infected, or all the above. So all of these cases, which ones qualify or would benefit most from PrEP?
Thank you very much. Which women may benefit from PrEP against HIV? Those diagnosed with gonorrhea in the 6 months, those diagnosed with syphilis in the past 6 months, those who have partner with HIV, all of the above. I've launched the polls. Please go ahead and take your pick. Which one do you think is correct here?
I like the way these answers are going. Very interesting.
So is it those diagnosed with gonorrhea in the past 6 years, those diagnosed with syphilis in the past 6 years, or is it those who have a partner with HIV, or all of the above? Okay, so just give you 5 more seconds before we share how people have managed to poll.
It's tricky, really.
Okay, I'll end the poll. Thank you very much. We've had 67% participation. All right, so there is your answer, C and D. Most people prefer D, and C is an option.
Okay.
So you can take us to the next question, to the next session.
So who would benefit most? A woman or man whose partner is HIV positive. So those of you who answered the C, I guess this is where you are coming. Then there's also a woman taking PrEP who subsequently becomes pregnant and remains at substantial risk of HIV infection. So you're already a PrEP client, then you become pregnant, but you still feel you're at risk. It means they can still benefit from PrEP. A man, woman, or young person who's HIV negative, living in a setting with HIV, high HIV incidence like Zambia, and who is at substantial risk of acquisition. So this one is very important because Dr. Ziamba, I remember there was a time people were saying, no, so you're saying everyone is a candidate for PrEP, as long as, you know, I'm a man or woman and I'm HIV negative. No. Yes, you qualify for the fact that you're high in a high incidence place like Zambia, but the question is, are you at risk? So only those who are proven at substantial risk qualify or would benefit most from PrEP. So it's not a must. And of course, any HIV negative key populations, I believe here we should have said key and priority populations, of course, within the legal ages of consent.
Very, very important aspects. Thank you for emphasizing that. I'm sure we'll have quite a number of questions in the chat. We can move on to the next slide.
So this one is a bit of an old one. We might need to revise it, but most of the information is still the same. So when we're at a facility, we try to see who's eligible. We have a criteria that we put in place. Obviously, the first thing is you have to test HIV negative. Secondly, we should not suspect, should not have any symptoms of acute HIV infection. And you have to be at substantial risk. This is where now we look at the different circumstances in your life that might put you at risk of HIV infection. Then there was the creatinine clearance, which we said it had to be more than 50 mils per minute, or protein in the urine, a proteinuria of more than 1+, or 2+ for pregnant women. So this is what we are currently using in Zambia, but based on the WHO recommendations, we might just revise this, And most importantly, no risk of intimate partner violence. We do not want your taking PrEP as the reason it should cause you to be at risk of violence with your partner. A lot of women have recorded IPV, GBV cases because they were found to be taking PrEP by their partner who was not happy, saying, so you think I can give you HIV? So this is the eligibility criteria that we have in place.
Thank you.
So, sorry, this looks a bit busy, but it's just sort of like a guide on how to provide PrEP. And so the first thing is we look at the populations. Who, remember the who are we providing it to? Then we have to look geographical areas. What might work in a rural, remote population might not work in an urban setting. So we have to look at geographies. How easy is it then to access these services? We have to look at the population. Who am I targeting? And which method will work best for them? Then we also have to look at your sexual risk behaviors as well. Then when it comes to offering PrEP, how do we offer it? The first thing is we make the services welcoming and client-friendly. Most of us already judge. The minute you see me going to PrEP, the sexually active, she knows what she's been up to, judgmental already. So we make it friendly, welcome, and open so that people feel that, I'm welcome and I'm doing the right thing. We already mentioned it has to be a package. So don't just say box of condoms I'm offering or PrEP, then I'm offering HIV prevention. It has to be a whole package you're offering. There has to be easy methods for linking someone to ART should we find that they are HIV positive, okay?
Yeah.
Those who request, someone might come, I really want to be on PrEP. Don't just say, but why? Tell us. I can now, okay, yes, they should share and say, look, I live in what do they call marriage by correspondence. My husband works here, I work here. So I feel I'm at risk. So be able to explore these methods with them. Then, as I mentioned, provide it in a combination with other packages. Where do we offer these? In places where we know PrEP demand can be generated. I think we've seen we're now taking it out into the community. So we even want to have mobile clinics, maybe like at bus stops, social gatherings, places where it's easy, we can get this demand. near brothels and such things. These are things that we're exploring. Then we also have to integrate it in other services. We've seen this being done in the ANC clinic where they've combined providing family planning with PrEP. So in other services, we're trying to introduce this in BMMC as well and other clinics. We can offer it in already existing structures, but we also feel, like I mentioned, mobile service delivery models might work. How to initiate? Let's look at the communities. Yes, we should look at a client-centered approach, but also look at the community they're coming from. They'll need support in staying on this. Then we have to build awareness, create demand, train the providers who will be offering it. But here, I think what I forgot Dr. Ziambo to mention is, first of all, we need to build knowledge. We still have so many people don't know what PrEP is in Zambia. We receive calls 22 hours from local radio stations saying, do you just have 5 minutes to spare to just tell us what PrEP is? So the first thing here should be to build knowledge. Yeah. Okay. When do we discontinue? When do we decide that I'm not over prepping? When is it okay to stop? The first thing we have to look at is, okay, you have to look at other factors, but the first thing, obviously, they're still negative, that's one, or they've proven positive and now they have to start ART. But the first thing is the risk. Is the risk still there? Is it still existing? Has it worsened? And other factors surrounding it. So the first thing, they test positive, yes. Are they adhering to PrEP? Remember, we said PrEP is effective when used consistently and correctively. So if they're not adhering, we cannot keep you on a drug. These drugs are expensive. As it stands right now, it's $28 per monthly prescription of PrEP. So that's money, and that's a lot of money coming from taxpayers. So this is something we need to look at. Then what if they decide they don't need the PrEP or want to? You cannot force them. Even if you feel I'm still at risk, but if I feel I don't need to, I don't want to, you should be able to discontinue this, because even if you give me the thing, I'll throw it out on my way out of the facility. Then if I no longer meet the eligibility criteria, which we discussed, and if there's safety concerns, if those safety concerns outweigh my benefits, because I don't want to offer you PrEP and tomorrow hear that you've been beaten to death, murdered. So if there's serious safety concerns about gender-based violence or intimate partner violence, we still should discontinue the PrEP. And those who develop kidney, renal diseases, or any PrEP contraindications. So that's the end of my presentation. I hope we've highlighted a few things and it's brought out a few things. I'd just like to summarize what we've discussed, just to remind us that combination HIV prevention is talking about offering a combination of interventions that are designed to meet the needs of specific people and communities. And PrEP should be offered as an additional method and not a one-off intervention to other existing interventions. Then all HIV negative individuals who are at risk or perceived substantial risk should be offered PrEP, and PrEP can be safely discontinued when no longer at risk. Thank you.
Thank you very much. It's a lot of information. Okay, so I think I've taken note of a number of questions in the chat box, so we'll get back to them, but for now, I wanted us to just run through the 4 questions. Then we'll move on to Senanga. I hope, Senanga, you are ready. Please prepare yourself. We'll be calling on you soon. So, team, here, which one is the correct answer here? For question 1. HIV prevention program should be tailored by. Sorry, this is the one that we did at first. Let me send in a new one. So how are we doing so far? Please go ahead and pour your questions. Okay. So I'll give it to you for 30 seconds only, and we see how we're doing so far. So far, over 96% of the people that have voted think E is the answer. Dr. Wupe, your comment on this.
Okay, so as we mentioned, that the new phase of HIV prevention is to look at all factors. So what will be required for certain ages, even your gender, what might work for women might not work for men. Hence, some newer methods coming out. We have to look at the culture, the social behaviors, environmental factors. So really, here all the answers are correct. It was all the above.
Okay, thank you. We've relaunched another one for question number 2.
This one I think everyone will get right.
All the following are effective current preventive methods of HIV infection, except A, safe and protected sex, use of available vaccines, use of sterile injection needles, safe blood transfusion and method. I think you are right. It's 100%. All the
100%. Oh no, actually no. We still have some C's.
okay. Okay, I'll end the poll. Maybe you could talk through these ones.
Sure. So we know safe, protected sex. So obviously, if somebody is using a condom, then we know that at least there's some protection there. So obviously, this is a method that we've chosen, and then especially with the ABCs, the C part, the condom, that's a method we've taken in Zambia. I'll move to C, sterile injection needles. Also correct, yes. That's a method we've said that you cannot be reusing or sharing needles.
Yes, they're sterile.
They're sterile. So this is a method as well. Then safe blood transfusion method. And I think the blood bank already does that. They screen for all these diseases before they offer someone's transfusion. On the vaccines, yes, I know people have heard about the HIV vaccine. However, it has not yet been proven. Some at the new at the HIV conference, I think some new data came out that they're still having misgivings with the findings. So it has not yet been recommended as a method of HIV prevention. First globally, more so in Zambia. So that was the wrong answer. So those who got that one correct. Yeah.
Okay, poll question number 3.
This one should be easy.
The following regimens are recommended for PrEP use in Zambia, except.
Remember the except.
Except. Tricky question, except. So I'll give you a few seconds for this one as well. Okay, I'll end. That's how people, I think D is the exception to
Yes, because D is now the first line regimen in Zambia, but it's not what we're using for PrEP. PrEP is the 2 drugs combined.
Next question.
Who may benefit most from PrEP in all those scenarios?
Which women? Very tricky scenario, this one.
Excuse me.
Is it those diagnosed with gonorrhea? Those diagnosed with syphilis in the past 6 months? Those who have a partner with HIV? All of the above? Ha. Okay, so this one I'd given you about a minute, and we only have a few seconds before I end the poll. And only 56 have voted so far. 56%.
Have people dropped off the call?
No, I think we still have. Okay, I'll end the poll. Dr. Thompson, please speak to this one.
So just off the bat, having an STI in the past 6 months, puts you at higher risk, means you're still at risk. So therefore, it already makes you a candidate for PrEP. That's one. Then two, obviously, a partner having HIV or being HIV infected obviously puts you at risk, because then you're at a serodiscordant couple. So here it was all the above.
So 6 months only, or how far can you go?
So they say 6 months. Newer data is saying we should actually say up to a year, because it means one, you're still sexually active. So they say we should give it a year, because like, let's say for those who live in couples, maybe you live apart. 6 months, obviously, if that's the time they are away, you can survive. But once they come back, the risk is still there. So that's why they've said maybe 6 months is not enough. We should move to a year maximum.
Okay. Okay, thank you for that clarity. So right now, we'll just ask a few, those that were comments. If you want to raise your hand, please go ahead and raise your hand.
All those questions.
And I've got some questions here. I know I've got panel experts on the call. Please, if you could also respond to some of these questions being raised in the chat. We had one here: in the event that someone who is PrEP
Who is on PrEP, I'm sure.
seroconverts to HIV positive, could there be a chance that someone can have drug mutation? Any comments on that? Then is PrEP recommended in clients whose sexual partner failed first-line treatment and they are on second and third line? Those transmission of mutations. How long can client be on PrEP? And in cases of seroconverting to HIV positive, what regimen is recommended? Maybe you can pick up on those before you proceed. Then I'll get back to the two hands that have raised their hands. Maybe you can comment on that.
Oh, so first a comment before the hands, right?
Yes.
Okay. All right. So in the event that somebody seroconverts, what are the chances of having a drug mutation? So we know there's different factors that influence drug mutation. So remember, we also have to look at the adherence of this person whilst they were on PrEP. Those are things that could influence it. But remember, PrEP is only 2 drugs and not a third one, as opposed when we start full-fledged ART. So if we do resistance patterns, most of the times you're still sort of sensitive to the 2 drugs, and we'll just add the third, the DTG, in an addition so that it becomes a full-fledged ART. However, like I mentioned, before we consider this, we'll have to look at your adherence patterns and all these other things that can influence, and also things of reinfection, your sexual habits that could influence drug mutation. I don't know if any of the experts can add on that.
We can move on to the next part. Is PrEP recommended to clients whose sexual partner failed the first line? I think that's more in the same lines. Discordant couples, but with one on probably third line or something like that.
So already tells you a lot about their adherence. There's issues of reinfection. So definitely PrEP will be recommended. But what we'll have to do is maybe look at the drug regimens that this person is on and look at resistance patterns. So in this situation, I would recommend we do a resistance pattern just so we know which drugs would be efficacious in such a person.
Yeah, I think these are isolated cases, and probably would require much more specific person-centered care. And you won't get a lot of those, but when you encounter such a one, it's important that you liaise with the advanced treatment centers where you can agree on something that is workable for their partner. In case because there are so many ways you can go about it. What you may want to make sure that the viral load they are undetectable and all those things. So should be very, very person-centered. Just the last question before we pick some questions. How long can a client be on? How long can a client be on PrEP? And in cases of social seroconversion to HIV positive, what regimen is recommended?
Okay, so how long? As long as you're at substantial risk. I know there's been issues as in, so if it means I can be on PrEP for life. Well, we have to look at substantial. That's why you saw us insisting on the substantial. It has to be a heavy case of risk for us to keep you on PrEP. And first line regimen, like I mentioned, if there's been no issues with adherence and we look at your sexual patterns, we would just add the traditional first line, the recommended first line, which is the DG-based regimen.
So I know we've got some experts on the call. Please do step in and you can make your comment. So for now, can we hear from Dr. Mazinga? Please, you can unmute and make your question. Then after that, we'll hear from James Kalenga in Senanga.
Okay, thank you very much for that. I have a question on PrEP on demand. Looking at the French IPREC study that looked at the adherence issues that was on the commercial PrEP, which it was noted that 50% of clients on the commercial PrEP had dropped and they were not as adherence. But with the PrEP on demand, it rose the percentage to more than 90% for adherence, and it has been good in male patients. So my question is, why isn't Zambia adopting the PrEP on demand in our curricula?
Very good question. James, please ask your question or comment before Dr. Msonda and the experts.
Good afternoon.
Afternoon,
I just took note of the recommendation, which was saying that HIV self-test kit will make additional value to PrEP or something like that. Now I wanted to hear because currently we do not consider the test result from a self-HIV test or quick as final test result. How is it going to make additional value, or how are we going to utilize that particular test results if we don't consider it as the final test result, or are there means to actually adopt it as a test result, or are we going to have an improvement on the current oral quick, or have something more improved on that can be used as also as a test kit or result?
Thank you very much for that important question. So we turn to our experts on the call. Dr. Michael, would you like to make a comment on that? On one of those questions?
Good afternoon, Dr. Ziambo, and thank you, Dr. Musonda, for the brilliant presentation. On PrEP on demand, that is the IPAGE study. Yes, it has shown to be very effective on men because here they've shortened the periods where you should take tenofovir. So we are talking about a loading dose of 2 tablets, 2 to 24 hours before indulging, and to discontinue PrEP 24 hours after sexual contact. So the first study was done on male clients, that's the IPAGE study on male only, and it was shown to be effective at 86%. We know that the rectum mucosa is quite sensitive compared to the vaginal mucosa. So this is when WHO now want to roll it out to the general population. So as a country, we can't just go in a direction where the study has been done on men having sex with men. So how do we do that? How do you implement that in a country like ours, where you come with an interventions? The evidence that we have is, yes, quite high, 86%, but only on MSM. So the latest recommendation by WHO, this is now when they're also having evidence that actually it can also be effective in women. So it has to wait a bit before we embrace that as a country. So the other question on the oral self-test kits. So yes, for now, it's not the definitive test because we know even the turnover, it takes some time before detecting a positive case, and you still have to confirm with determine. Even if we go into the community, we do the same for PrEP. As long as you're negative, we know the test is quite sensitive. If it's negative, it's negative. But when it's positive, that's when we confirm. So it will be the same even for PrEP clients. If the turnout to be positive in the community with an oral self-test kit, then they still have to come to the facility to confirm. And if that is confirmed, then we switch them into treatment. I think those are the 2 comments that I would like to make at this point. Thank you.
Very, very important comments. Thank you for coming through, Doc. Dr. Mungomba, your last comment before we ask Senanga team, kindly prepare yourself. Just drop my share. You can prepare yourself and share your slides. Dr. Mungomba, go ahead and make your comment.
Thank you very much, Dr. Ziambo. Thank you, Dr. Msonda, for this wonderful presentation. I just wanted to make a comment on this question, which was asked on the platform in regard of how is the retention, PrEP retention in Zambia. So what is actually happening now? We have an improvement, because before 2022, in 2021, we're only accounting for all those who have been put on PrEP before. And that was our PrEP card. So whoever has been given PrEP before was accounted for. So now that indicator was not really giving much importance to the prevention itself. So now we have moved into PrEP kitting, where we are considering, which is continuity in treatment. So where we are supposed to actually track all those who come for refuel and all those who come for reinitiation. So by doing so, all the clients we are having, all recipient of care we are having getting PrEP are actually tracked if they are getting their refuel, and all those who are not able to come, we are actually ensuring that we make a follow-up up to community level and ensure that they are given their medication. So with that, it has actually improved the retention in the country. So now going to the question which was asked in regard of PrEP vis-a-vis to HIV type 2. But of course, if someone who is HIV type 2, that person is not entitled for PrEP, can go for full HAT. But if the partner is the one who is actually HIV type 2, I think PrEP still stands. But the backbone in all this is adherence. If you have a partner who is adherent, at the end of the day, it will be undetectable. That is viral load, and definitely it may not transmit. Thank you, Dr. Ziambo.
Sorry about that. I think our colleagues have forgotten to mute themselves. Thank you for those comments. I'll invite the experts just to respond to some of the questions. We've run out of time. Kindly respond to some of the questions in the chat. I've asked quite a number of questions. Please respond, and I'll allow the Senanga team to make their presentation. Victor, please go ahead.
Okay, good afternoon, everyone. This is a case presentation from Senanga Urban Clinic. As you see, we are presenting a case that is in line with what was being presented there. So, okay. Sorry, my slides are not moving. Okay. So what we are having is a case of a male, 29 years old, initials AM, who was born on the 23rd of April, 1993. This is a client that we had started on PrEP some time back in 2021. So the client first started PrEP on 4th of May, 2021. And looking at his socioeconomic status, he is a businessman who does the fish business. He is married, and a partner is known to be HIV positive on ART. And from the history, we could get that the client usually has unprotected sexual intercourse with multiple partners. And that's why he came for PrEP, so that he can find his prevention. So as we said, he started his PrEP on 4th of May 2021, and he was also linked to other preventive services like VMMC and the use of condoms. So far, he has had up to 5 visits from the time he started PrEP up to this time. So looking at the history as of the time he came on 3rd August 2022, the vitals that were done, his weight was at 68 kg, his height was at 169 centimeters, and his BP was at 123/80 millimeters of mercury. When we calculated the BMI, it was at 23.8, and he didn't have any presenting complaints at that time. So as per screening for the acute HIV infection, the screening was done, and there was nothing abnormal that was detected. And then on the STI screening, using the question that we asked, there were no STIs that he had at that time when he came for the visit. Then his condition was generally stable. And then when it came to the screening for side effects, the screening was done and there were no side effects that were being experienced by the client. So on that visit, we planned to say he continues PrEP and be given 3 months dispensation. So also there are lab investigations that have been done, as you see on the next slide. So among the investigations that were done were one of them, the HIV status that was done on 4th of May 2021. The HIV test was done and it was negative. Then we couldn't do the kidney test because we didn't have any reagents at that time. Then on 5th of May 2021, still we couldn't do the kidney function test, but the HIV test was done and it came out negative. And then on the urinalysis, which was done, there were normal findings. Then the same thing again on 1st of February 2022, we couldn't do the kidney function test, but we did the urinalysis, which came out normal, and also the HIV test was done. Then again, the next visit was on 4th May 2022, where we didn't have the reagents for kidney function tests, but we were able to do the HIV test, which came out negative. Then on the final visit that he came, that was on 8th of last month, we didn't have reagents for the kidney function test, but the HIV status was done and it was negative. And also we did the urinalysis, which gave out normal readings. Then we wanted to share also on the partner. As we said, that this is a client who is married. So he's married to a female MS who is 28 years old, who had started ART on 31st of March 2020. And as of now, she's pregnant with her LMP on 2nd of April 2022. And she's expected to deliver on the 9th of January 2023. She's a Gravida 2 para 1. So she first booked here at Senanga Urban Clinic on 5th of August 2022, and she did a second visit on 6th of September 2022. So looking at our VL profile, you find that starting from 2020, this is a client that has been suppressed. So 30 September 2020, it was at less than 30 copies. And then on 2nd of March 2021, it was at less than 30 copies as well. And then on 2nd June 2022, it came out as target not detected. And then on 6th of September 2022, it came out target not detected. So according to this case, we have 4 questions that we wanted us to discuss. The first question being, what other history elements would we have taken into consideration to get a comprehensive history from the client? So that's question number 1. Then the second question is talking about what considerations should be put in place for clients intending to stop PrEP. And the third one is asking on the DSD models that we can use in PrEP dispensation, where we're asking about, can 6 MMD be considered for clients that have been consistent on PrEP and very adherent? Then the final one is what other services would we have offered to help the client? So basically, this is the case that we have as Senanga Urban Clinic that we've brought for your attention today. Thank you.
Very, very, very involving case, and we really appreciate your taking time to share this. So I will quickly ask the network for any particular questions. If there's any questions of clarity that you have, otherwise then we can proceed to discussing the questions. Yes, Mary Mumbi, you can unmute yourself and ask a question.
Good afternoon, everyone.
Afternoon.
I'm going to answer question 3.
Okay.
On the dispensation of 6 months PrEP. For me, I would say it's no, because sorry?
I was asking the team to move the slides to the questions. Thank you. Go ahead, Mary.
Okay. I'm saying on the dispensation of PrEP for 6 months, it's a no-go area, because we are looking at testing a client every 3 months. So the client has to be tested every 3 months. So giving a 6 months dispensation of PrEP, it's a no for me.
Thank you very much. I saw another hand. They've put it down. So we can hear from the other colleagues. What do you think? Is there something else that the team could have considered in their history? There's a clarification question here. Did the wife have a high viral load at some point?
Can I answer that one just now?
Yeah, go ahead.
Okay, so for the viral load, that profile that we gave was the only history of the viral load for the client, and there's never a period when the wife has had a high viral load. So these were the readings that they had, and they were suppressed at all times. Thank you.
Thank you so much. Bubala, Innocent Bubala, you have a comment, and then we'll have a comment from Dr. Mundia. Innocent Bubala, please go ahead. Okay. Dr. Mundia?
Good afternoon. Thank you, Dr. Ziambo. Thank you for the presentation. I'd just like to ask you to go back to your first slide where the history is. I just want to comment on a few things. This is a very good case that we can look at in different ways, but I'd like to just focus on the gentleman that you have presented. Despite the fact that the partner is virally suppressed, we already would translate that to U equals U. But the partner has, the male partner has multiple other partners, which of course it would be very important for us to just kind of identify who exactly this person would be having sex with. So that already puts this gentleman at risk, despite the fact that the wife is virally suppressed. So this person already is eligible for PrEP. So one thing that we needed also in the history to find out is how is his condom use? Is he consistent with condom use, and how well is he using these condoms? But already he has noted that out, which is fine. Another thing also that would want to ask is, alcohol use. Oftentimes when clients do come and come to access PrEP, we as clinicians forget to ask about alcohol intake. If it's somebody that abuses alcohol, he's definitely going to forget about his dosage for PrEP. So we always need to make sure we do ask that. When we look at STI screening, if we all look at that form that we use for PrEP, we ask about symptoms that people would have had. So we always, again, I think it would have been nice in this presentation to mention whether there was any previous history of STIs like syphilis or gonorrhea, chlamydia. That again will broaden your umbrella to say that he's really at risk of HIV infection. So that also needs to really come out. Otherwise, good presentation. I just wanted to find out also, did we at any point in time have a syphilis test done or hepatitis B test done for this client on PrEP?
Okay, thank you for that question. On it was just the screening that was done for STIs. We didn't do any lab tests for STIs or for hepatitis B. I think that is something that we can still do since this client is scheduled to come back in November. So we can still try to work that out and make sure it's done also. But no, it wasn't done. Thank you.
Okay, thank you very much. Very important comments there. There was a hand from Livingston PCOE. Would you still want to make a comment? Livingston PCOE, I saw a hand. So what consideration should be put in place for clients intending to stop? Any comments on that? And I think there was also a question in the chat saying, if a client says you'll no longer be exposed to somebody, can we stop the PrEP? Yes, Innocent, are you able to unmute yourself now?
Yes, I'm having a challenge with network now.
Okay, go ahead.
Yes, my comment, I don't know whether it has been given already, but I think another thing that we need to do is we need to put more effort on creatinine levels on this patient. I mean, on this client who's on PrEP. Then to answer question number 2, what are considerations that should be put in place to stop? I think for this one, let's make sure the woman is no longer, because remember this woman is pregnant currently, so at any time we can have even again the viral load detected. So with me, I think I would advise the team that they wait at least this time until the woman is somewhere in the cessation of breastfeeding or when it is done with the antenatal.
Thank you very much for your comments. Ray from Livingston PCOE.
Thank you so much, Chair. This is Ray Shem from Lewanika Pediatric Center of Excellence. Just want to give an attempt.
Sorry, apologies.
Yes. Thank you. Just want to give an attempt on question 2, which says what consideration should be put in place for clients intending to stop PrEP. So first we need to assess and assess if this client is still at substantial risk of HIV acquisition. So this includes assessing for sexual partners. If this client still has other multiple sexual partners, that can pose a risk of HIV acquisition. And then if they don't have, then maybe we can consider them not to be at substantial risk. And then the other thing is if, for instance, they are already in discordant couple, we need to assess if the other partner has attained TN viral suppression, which is TND in this case, and also assess if we can also advise to use other preventive services. This includes condom use to be used to be used. We can also use this criteria to assess if whether they can stop or not. Thank you.
Thank you. Very important comments there. Thank you so much. It's been very active and participatory. I know we are now remaining with a very few minutes before we wrap up. There was just, I think, the final question, number 4, I think, where we would have loved to hear more. Maybe Dr. Wupe might say something on this one. Maybe just to wrap up, Dr. Mtonda, maybe you can make a comment on this case.
Yeah, well, firstly, thank you for such an interesting case. And because not just is this just any client, it's actually one of the key populations, the migrant populations, who are quite a challenge when it comes to offering HIV prevention services. So I'm happy that you picked this case. The first thing I'll speak about is the risk perception. We have to look at this client. Had you said this client has got multiple partners with condom use, it would be easier, but with unprotected sex, it means this person has a very low risk perception of himself. So it would be very good to explore this person, how they perceive themselves at risk. Is it that they think de facto that the fact that no, maybe some load that is covered from my wife who is no longer detected has transferred on to me? Like, it would be very interesting. We need to explore this person's risk perception for having the sexual habits that they do. We also need to consider indexing some of these same people or his multiple. The fact that he's migrant might be hard to locate where these people are, but it would be good if we could somehow do some indexing on these. The only other thing I'll speak about, the lab challenges. I know it's easy to say you could have done this, but when it comes to lab, I think this is like a nationwide problem. Reagents have been really, really hard in terms of stock levels. Sometimes they're available for a quarter, then the next quarter. So I think this is why one of the WHO recommendations is going that route, because they've seen the challenge in terms of having reagents. But like I said, where we do not have the creatinine, we still always have the urine analysis, which can still be an indicator to offer this. In terms of offering other services, I think the combination prevention aspects. So yes, we're happy that this is a VMMC client. Okay, I know you said offered, so I don't know if it means he's circumcised, but we need to make sure at least we're clearing all the edges. So we check his VMMC status. We've already talked about insisting on the condom use. Is it that he has a problem with condoms? I would also like to bring out an issue. Do you know that we have reported a high number of people who are allergic to our condoms because they have latex? So they've reported skin reactions. So maybe that's the reason he doesn't want to take the condoms, because he reacts. So we have to look at things like that. The only trouble is that the non-latex condoms are obviously, you have to pay, they're not free, and they're quite expensive. So those are some of the things we might need to look at. Offering him the other services. We've already spoken about all these other risk perception and behavior change that we could instill on this person. And he's already a client for PrEP. We pray now that he'll be adherent to it. So I think we'll also need to look at, and then also need to look at the sexual behavior between he and his wife. Is it that he and his wife are not having sex and then he's having sex with everyone else? So these are also things that can influence how we handle this client.
Thank you very much, Dr. Wupe, very exhaustive. I want to ask Sananga team, are you or so far okay with the offers that have been given in terms of these questions? Are you comfortable with the questions that would have been responded to?
Yes, I would say we are. It has been tackled very well. And Yeah, I think it's very helpful. We'll work with the recommendations. Since this is a client that we still have and will still continue seeing, and would want to make sure that they continue to be on PrEP. So thank you for the recommendations.
And to the rest of the network, I do hope that this has provided a great representation of some of the cases and challenges that you are having, and you will be able to manage them as we go along. For now, I just want to say thank you to Dr. Wupem Sonda for taking time to be with us this afternoon. And I would like to say thank you to Sesenanga team for a great presentation. We appreciate what you shared. Our panel experts, Dr. Michael Kabongo, Dr. Mngomban, Dr. Mundia, and all those that managed to make their comments. Please, thank you very much. We look forward to being with you next time. Please don't forget to register. The link has been shared. Register before you disconnect. Otherwise, we've come to the end of our session this afternoon, and we'll